Okay, anyway, so our topic for today is bronchogenic carcinoma, which from the exam point of view is extremely important. You can expect a main question from bronchogenic carcinoma, means lung cancer, is extremely important. Mesothelioma is not that important, but bronchogenic carcinoma, that is a lung cancer, is extremely important from your exam point of view. And because it's a big topic, I'll be going a bit fast. So what's your knowledge about bronchogenic carcinoma? This lung cancer is one of the most deadly cancers in the human body. Lung cancer is one of the most dreaded cancer in the human body. And fortunately, we know what is the predisposing factor. Fortunately, we know what is the predisposing factor, what causes lung cancer. You know what causes lung cancer? What causes lung cancer? Huh? Yeah, smoking causes lung cancer. But unfortunately, we cannot get rid of smoking. It's very difficult for smokers to quit. And one more thing which is not actually fortunate, which is actually very unfortunate, is the trend of smoking among women who develop lung carcinoma, especially adenocarcinoma. And adenocarcinoma is most frequently seen in women than men. Okay, so that is actually an unfortunate thing. And even though women harbor breast cancer more than lung cancer, but they die of lung cancer more than that of breast cancer. You'll be studying that when I'll teach you breast cancer. Okay, so with this, I go to the etiology. The most important thing is smoking. How does smoking induce lung cancer? So there are three things that you have to remember when you study about smoking. That is amount of daily smoking. How much you smoke, how many cigarettes you have every day. That is point number one. The tendency to inhale. What do you mean by tendency to inhale? What is meant by tendency to inhale? How deep you take it. How deep you inhale. So the deeper you inhale, the smoke goes deeper into the lungs, into the periphery of the lungs, into the terminal bronchioles, the terminal airways. So how much you inhale, the deeper you inhale, the greater chance of developing a lung cancer. And duration of smoking habit, for how long you have been smoking. So remember these three, otherwise there is nothing much to tell you about this. Amount of daily smoking, how many cigarettes you have per day. Number two is tendency to inhale, how deep you inhale. The deeper you inhale, the more possibility of a human developing lung cancer. And the third one is duration of smoking habit. So these three you must remember. Okay. Then there is something called second-hand smoking. What is second-hand smoking? Huh? Passive smoking. How does that happen? I smoke, you don't smoke, but you inhale the smoke that I'm exhaling. That is second-hand smoking, and many non-smokers who do inhale smoke in this fashion, they are also predisposed to develop lung cancer, but definitely not more than first-hand smoking. First-hand smokers are definitely more exposed as compared to second-hand smoking, but that doesn't change the fact that second-hand smokers are not predisposed. They are not safe at all. Then comes industrial hazards. What are industrial hazards? Just remember these points. High-dose ionizing radiation. That can be one thing. People exposed to uranium, even though they are more associated with mesothelioma, but people exposed to uranium, asbestos, they can also, radon, etc., etc. They can also develop lung cancer. So one is smoking. Number two is industrial hazards, and then air pollution. Sorry, that comes under air pollution, radon. That can also happen. So these three things you must remember, and then there's one more point, that is the genetics. That is also essential. So any questions from here? Any questions from here, etiology? There are four things. I have explained to you three things. And the fourth one is molecular genetics. Molecular genetics, you must remember the proto-oncogenes and the tumor suppressor genes. The proto-oncogenes and the various tumor suppressor genes, that must be at your fingertips. You have to answer those. Now, so when we talk about genetics, there are three things that you must remember. Two points. So molecular genetics. So you must remember proto-oncogenes and the other suppressor. So a few proto-oncogenes like CMYC, CMET, CKIT, EGFR. So these are the various proto-oncogenes that are involved. These are the proto-oncogenes that are involved. Then comes tumor suppressor genes. So which are the tumor suppressor genes most commonly involved? One is P53. Have you heard of P53? You have read neoplasia, so you have heard about P53. So that is, what is it called? The molecular policeman. Okay, or the guardian angel of the genome. Then comes RB. Huh? God, that's what I said. Guardian angel of genome or molecular policeman. Then RB. What is RB? Retinoblastoma gene. The retinoblastoma gene. So on one hand, you have proto-oncogenes, which undergoes mutation, and the other is tumor suppressor genes. So which are the proto-oncogenes? CMYC, CMET, CKIT, EGFR, etc., etc. These are all the proto-oncogenes, and the various tumor suppressor genes, at least named two important tumor suppressor genes. If you were asked, mention about P53, also known as the molecular policeman or the guardian angel of the genome, and the number second is RB, retinoblastoma gene. This you must remember. So this cancer doesn't happen all of a sudden. The cancer doesn't happen all of a sudden. If we consider squamous cell carcinoma, if you take a biopsy of a person who has been smoking for a long time, you see certain changes at the level of histopathology, and these are known as the precursor lesions. Precursor lesions. So it undergoes, first and foremost thing, what happens is the respiratory epithelium undergoes. The respiratory epithelium undergoes what? Metaplasia. Very good. Squamous metaplasia. Again, after a prolonged period of time, the metaplasia undergoes what? Dysplasia. And then dysplasia progresses to malignancy. So there is a sequence of events which takes time. It doesn't happen all of a sudden. You start smoking and maybe in a week you develop lung cancer. No, it doesn't happen so quickly. It takes a lot of time before a lung cancer to develop. And if you follow a patient up, or if you follow persons who has been smoking for a long time, you take a biopsy, you can see certain changes in the respiratory tract. The respiratory epithelium undergoes metaplastic change into squamous epithelium. So there is a metaplasia that is called squamous metaplasia. Then again, after a prolonged period of time, after a latent period, maybe it's very difficult to exactly say how long, but after a prolonged period, it develops dysplasia, and dysplasia progresses to, again after a latent period, progresses to malignancy. So there is a sequence of events. So squamous dysplasia and carcinoma in situ. You know what is a carcinoma in situ by now? I'm not explaining it. Okay, you know what is a carcinoma in situ. Then diffuse idiopathic neuroendocrine cell hyperplasia, also called DIPNEC. Diffuse, just remember the name. This is at the PG level. DIPNEC is at the PG level. And then atypical adenomatous hyperplasia, more commonly associated with adenocarcinoma. So the first one, squamous dysplasia and carcinoma in situ, that is associated with squamous cell carcinoma. Then comes DIPNEC, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, DIPNEC, associated predominantly with the bronchial carcinoids, associated with the neuroendocrine carcinoma, the most dreaded of the lot, small cell carcinoma. And then comes atypical adenomatous hyperplasia, predominantly associated with what? With the adenocarcinomas of the lung. Okay. So these are the various precursor lesions which you can make out here. So this is basically what? These are all the dysplastic and the metaplastic changes. See, you can make out this is the Respiratory epithelium, right? Why this is a respiratory epithelium? Can anyone tell me? Huh? Yes, exactly. Very good. You can make out the cilia. What is the function of cilia? Why you have cilia in the lungs? Filter out the unwanted things which you inhale. Okay. So now you compare this picture with the picture over here. This is definitely undergone dysplasia. See, the cilia is gone. The cilia is gone. The cells from the respiratory epithelium is changing into squamous epithelium. That is metaplastic change. And when you compare this part and this part, these are all this is highly dysplastic, maybe carcinoma in situ. That is carcinoma in situ. So these are the various lesions. Then this is an atypical adenomatous hyperplasia. This is dip neck. Just remember the names. You may not be, it's not possible, it won't be possible for you to remember everything. Even at our level, we do not remember if we don't read. So at least know the names. Squamous dysplasia, squamous, they won't ask you to draw this diagram. They won't ask you how the cells look like, but they'll ask you the names. If you can answer the names to the examiner, that's more than enough. So squamous dysplasia and carcinoma in situ, that is one precursor lesion giving rise to predominantly squamous cell carcinoma. Then you have what? The dip neck, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, predominantly giving rise to neuroendocrine carcinoma. And then finally the atypical adenomatous hyperplasia. This is the atypical adenomatous hyperplasia, maybe a precursor to adenocarcinoma of the lung. Okay, so these are the names, the squamous, these are the, so these precursor lesions, at least remember the names of the precursor lesions. Okay. So classification. For all practical purpose, if someone asks you, how do you classify lung cancer? If you go with the WHO classification, it's massive. You cannot remember everything. But, and don't straight away jump to this answer like, okay, squamous cell carcinoma, adenocarcinoma, fine. At your level, that's good enough. But for practical purpose, if you classify it like this into small cell carcinoma and non-small cell carcinoma, small cell carcinoma and non-small cell carcinoma. The small cell carcinoma, they represent around 20 to 25% of lung cancers. They represent around 20 to 25% of all lung cancers, predominantly arising in the central portion of the lung. The location of the lung cancer is very important. Small cell carcinoma and squamous cell carcinoma, they predominantly arise from the central portion of the lung. Predominantly, not necessarily always. Predominantly, they prefer the central portion of the lungs. Whereas the non-small cell carcinoma like the adenocarcinoma, large cell carcinoma, they prefer the peripheral portion of the lung. Okay, so for all practical purpose, divided into small cell carcinoma and non-small cell carcinoma. The small cell carcinoma is predominantly the neuroendocrine carcinoma, that they are the worst of the lot. The prognosis is dismal. If patients develop this kind of lung cancer, the only treatment is chemotherapy and the median survival is very poor. They are the worst, they are the deadliest of the lot. Small cell carcinoma. And then you have the non-small cell carcinomas. One is small cell because, as you can make out by the name, the cells are small in size. But when you talk about the non-small cell carcinoma, non-small cell can again be divided into squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. So you may have read in the books about a carcinoma, if you have read about lung cancer, or if you have heard about something like this, there's an entity called BAC. What is BAC? Bronchoalveolar carcinoma. Bronchoalveolar carcinoma. That is basically a subtype of adenocarcinoma. Basically a subtype of adenocarcinoma. Okay. So non-small cell carcinoma, they can arise both in the central and peripheral portions of the lungs. So which non-small cell carcinoma arise in the central portion of the lungs? The squamous cell carcinoma. The large cell carcinoma and the adenocarcinoma, they predominantly arise in the peripheral portion of the lungs. Again, I am saying it's predominantly, not necessarily it always has to arise from there. So this is basically a rough representation. Many of you keep on asking me where I take this, which book to follow. I'm again telling you, it's available in the library. I've seen it. Vinay Kamal, they give these beautiful diagrams they have. For exam purpose, I haven't seen a book which is more beautiful than this one. Because he gives you everything over here. See, everything is given here. What kind of carcinoma? See, this is an adenocarcinoma. This is an adenocarcinoma. This is a bronchoalveolar carcinoma, which is a subtype of adenocarcinoma. Where do they arise? This is the periphery of the lung. Isn't this the periphery of the lung? This is the periphery of the lung, right? Whereas, see this, squamous cell carcinoma, small cell carcinoma, they predominantly arise where? In the central portion of the lung. So remember, see this diagram and remember this diagram. This is very beautifully given in that particular book. And it has everything. It has everything. Look at all the symptoms it gives. Even it gives you the markers. Even this gives you the markers. So, an examiner may ask you about the location. Which location is preferred? Which is the preferred location for which kind of malignancies? So, adenocarcinoma, large cell carcinoma, bronchoalveolar carcinoma, they predominantly prefer which location? Central, peripheral location. Predominantly, again I am telling you. And squamous cell and small cell, they predominantly arise from the central portion of the lung. This diagram represents everything. So coming to the comparison which I have just explained between the small cell and non-small cell carcinoma. Small cell carcinoma are more deadly, even though they constitute 20 to 25%, but they are more deadly than non-small cell carcinomas. They predominantly arise in the central region of the lung and widespread metastasis. They metastasize very early. That's why they are so deadly. Prognosis is very bad. Whereas non-small cell carcinoma, you know which are the non-small cell carcinomas and how they behave. I have just explained you when I was telling you the classification, when I was explaining you the classification of non-small cell, small cell and non-small cell carcinoma. Okay. Now coming to the location again, I am not explaining this. Remember the location. Now what you have to remember is the cell of origin. The cell of origin. So now you know the first and foremost thing is for practical purpose, how do you classify lung cancer? Then number 2 is location, which part of the lungs are involved for which type of cancer. Number 2, classification, location, and then comes the cell of origin. Cell of origin. There are so many cells in the lungs. Which carcinoma prefers which types of cells? Or which is the parent cell of origin? So this is essential. The small cell carcinoma arises from the Kulischki cells. The small cell carcinoma arises from the neuroendocrine or Kulischki cells. Squamous cell carcinoma arises from the basal cells in major bronchi. Because they are in the central portion of the lung, they arise from the major bronchi, the basal cells in the major bronchi. Number 3, adenocarcinoma. Adenocarcinoma arises from the mucous glands in the terminal bronchi. Why terminal bronchi? That explains you the peripheral portion. That explains you because they prefer the terminal portion of the lungs, because they prefer the mucous glands which are present in the terminal bronchi. That is one of the reasons why adenocarcinomas arise in the peripheral portion of the lungs. And number 4 is bronchoalveolar carcinoma, which is nothing but a subtype of adenocarcinoma with a comparatively good prognosis. They arise from the Clara cells. They arise from the Clara cells in terminal bronchoalveolar region. Okay, so classification, now you know the classification for practical purpose. How do you classify lung cancer? That is one. Number 2 is the location, whether the central portion of the lung or peripheral portion of the lung. And number 3 is the cell of origin. The cell of origin is very important. This won't be asked for your theory, but you must know it because in exam, if I am the examiner, I'll prefer this kind of questions. These tidbits are very essential, and for you, I mean, MCQs and all, very important. They will definitely ask you. Okay, so is this clear? So let me proceed now to the clinical manifestations. Just remember the clinical manifestations: hemoptysis, chest pain, dyspnea, dysphagia, hoarseness of voice, etc., etc. Okay, just remember, chest pain is very common, and hemoptysis very commonly occurs where there is cavitation, especially in squamous cell carcinoma. where there is cavitation and necrosis. So these are the various clinical manifestations: chest pain, dyspnea, dysphagia, then your hoarseness of voice, lipid pneumonia, pleural effusion, more common with mesothelioma in the last class, which I have explained, but it can also happen here, rib destruction, superior vena cava syndrome, etc., etc. Horner syndrome. Horner syndrome, have you heard of Horner syndrome? Yes. When the sympathetic, cervical sympathetic chain is involved, especially Pancoast tumor. So I'll be telling you that. Okay, so this is the clinical manifestation. If you want, I will give you the slide. Now comes to squamous cell carcinoma. Squamous cell carcinoma is nothing but a, what kind of, if I ask you to classify squamous cell carcinoma, where do you put it? Where do you put it? Non-small cell carcinoma. Non-small cell carcinoma. Okay, small cell, and don't say large cell. Small cell and non-small cell. In that non-small cell, again you have adenocarcinoma, squamous cell carcinoma, bronchoalveolar carcinoma, which is nothing but a subtype of adenocarcinoma with a comparatively good prognosis. Then you get the large cell carcinoma with a very bad prognosis. So first, now let's come straight to the malignancy. Squamous cell carcinoma. At this stage, you should know how a squamous cell carcinoma looks like. Orko has taken a class on oral cancers. So he has explained you squamous cell carcinoma. So can anyone of you tell me what are the features? How do you grade squamous cell carcinoma? Differentiated and poorly differentiated. Have you heard of this? Huh? How do you make out a well differentiated squamous cell carcinoma? It's written there. How do you make out squamous cell carcinoma? Well differentiated ki hobe? You get the hemidesmosomes. What are hemidesmosomes? What are hemidesmosomes? This is your anatomy knowledge. Intercellular bridges, or junction and intercellular bridges, that is the hemidesmosomes. So you'll get the hemidesmosomes. Excuse me. Then comes keratin pearls. What are keratin pearls? Acellular collagenous deposit, which is surrounded concentrically by the malignant squamous cells, giving rise to a somewhat like an onion skin appearance. So that those are keratin pearls. So keratin pearls, hemidesmosomes, they represent well differentiated squamous cell carcinoma. They represent well differentiated squamous cell carcinoma. Then comes moderately differentiated carcinoma. On one hand, you have the squamous cell carcinoma. On one hand, you have the well differentiated squamous cell carcinoma, and on the other hand, you have a very poorly differentiated carcinoma, which by looking into the slide, you can make out it's very poorly differentiated. And in between you have the moderately differentiated carcinomas. The moderately differentiated carcinomas are the one which have some features of well differentiated carcinoma and some features which proves that the cancer is going towards a more bad phase. So anyway, just remember the names: well, moderate and poorly differentiated carcinomas. So the precursor lesions are known: squamous metaplasia or dysplasia, that is one thing, and carcinoma in situ, which is basically a cancer, only it's bound by the basement membrane. Now, sometimes these tumors, if they present with pleural effusion, or even sometimes they can be found in the sputum. So people suspecting a squamous cell carcinoma, if a doctor suspects a squamous cell carcinoma in a patient, he or she may ask for a sputum examination, which is basically under pathology a cytological examination. And if you do cytological examination of the sputum, sometimes we can find the malignant cells. So this typically, I'll show you this particular picture. This is basically a squamous cell carcinoma, which is central in location. So what kind of a growth it is? It is an endobronchial growth. Endobronchial growth means what? Endobronchial growth means what? It grows within the bronchus. So if it grows within the bronchus, what can it cause? If it grows within the bronchus, what can it cause? It will cause obstruction of the bronchus. It will cause obstruction of the bronchus, leading to what? Leading to what? If there is obstruction of the bronchus, what can happen? Huh? Obstructive lung disease, not exactly, but yeah, kind of, but what is the term? I'm looking for the particular term. Atelectasis. Lung collapse. There will be atelectasis. That's what squamous cell carcinoma will cause. Any kind of malignancies will cause. Okay, so it's an intraluminal pattern of growth, that is within the bronchus. With time, it can penetrate the bronchus. With time, it can penetrate the bronchus and grow into the substance of the lung. It can penetrate the bronchus and grow into the substance of the lung. And what is that particular growth pattern called? What has it been equated to? What? Squamous cell carcinoma ki. Amra khai. We eat. It has been equated to something which we eat. Eyes don't see what mind don't know. Eyes don't see what mind don't know. I mean, it has been equated to a cauliflower. Fulgopi. That's why I'm saying eyes don't see. So it has been equated to a cauliflower. Grow in broad front, producing a cauliflower-like growth. Grossly, the tumor is white, grey-white and firm. Bulky lesions can undergo hemorrhage and necrosis. And squamous cell carcinoma is the one which produces cavitation and necrosis. It has been divided into 3 grades: histologically, well differentiated, moderately differentiated, and poorly differentiated. Fortunately enough, squamous cell carcinomas metastasize very late. Squamous cell carcinomas metastasize late as compared to small cell carcinoma. That's why their prognosis is a little better than the other ones. Okay, so this is a picture which explains you everything. Where does it metastasize? The most common site of metastasis is hilar tracheobronchial lymph nodes. Hilar tracheobronchial lymph nodes. Then you get the extrathoracic lymph nodes like mediastinal and cervical lymph nodes. Which organs are involved? Liver, adrenal, brain, bone, spinal cord, pancreas. So these are probably hematogenous. So again you have the lymphatic spreading to the lymph nodes, and you get the hematogenous mode of spread. The hematogenous mode of spread predominantly goes where? To the liver, adrenals, pancreas, bones, brain, spinal cord, etc., etc. So these are the points where, these are the sites where they metastasize. Okay, so immunohistochemically, which are the markers? Just remember the name: P40, P63, cytokeratins, etc. CEA, EMA. So what is this? Now let me ask you one question. What is this? What is this? This is the keratin pearl. This is the keratin pearl, and look at this lesion. Look at this lesion. This is very much centrally located, a whitish, grey-white firm tumor mass. This is a grey-white firm tumor mass, and these are all the cytological examination. Just this particular cell, which you can see extremely eosinophilic and has a tapering end. Can you name the cell? This is known as a cordate cell. A tadpole cell, looks like a tadpole, Bangachi, right? So this tadpole cell, if you get in a cytological sputum, this represents squamous cell carcinoma. Okay. So these are all the malignant cells here. Now, before I go to the adenocarcinoma, of this, which is adenocarcinoma and which is squamous cell carcinoma? Can you tell me? And why? Left at adeno because it's peripherally located, and this one, this is adenocarcinoma because of the peripheral location, and this is squamous cell carcinoma because of the central location, but this tumor has become big. Now I'm asking you one question: what is this particular structure? What is this particular thing? What has it undergone? What has it undergone? Cavitation. Don't you think there is a cavity? If you compare this and this, it has, there is a border over here, and this is known as cavitation. And what are those fibril thing over here? This granular fibril thing. The tumor has undergone what? Granular fibril mass. What is it? Necrosis. So squamous cell carcinomas undergo cavitation and necrosis more commonly than other tumors. Maybe other tumors don't, but squamous cell carcinomas do undergo cavitation and necrosis. Okay. Next comes to the adenocarcinoma. See, why neoplasia is taught before all this, you know. Why? Because in neoplasia, you know how squamous cell carcinoma looks like and how adenocarcinomas look like. That is the reason why neoplasia, that is why general pathology is taught first, then we come to systemic pathology. So adenocarcinoma is characterized by what? Glandular differentiation. Adenocarcinoma is characterized by glandular differentiation. It can be acinar, it can be papillary, bronchoalveolar, solid, etc., etc. Predominantly seen in women. Predominantly seen in women and non-smokers. Predominantly, of course, smoking is one risk factor, but not as much as the correlation of smoking with bronchogenic carcinoma is strongest with squamous cell carcinoma and small cell carcinoma. Then comes adenocarcinoma. Adenocarcinomas are peripherally located. Adenocarcinomas are predominantly peripherally located, and they can be graded into well, moderate and poorly differentiated. I am not explaining now what is well, what is moderate, what is poor. It has been explained to you many a times. Okay. Then again, metastasis, the same metastasis, hilar-tracheobronchial, extrathoracic lymph nodes, and then the same organs like the liver, adrenals, bones, kidney, etc., etc. Pancreas, spinal cord. So these are all the sites where they spread. Immunohistochemically, they are positive for cytokeratin, epithelial membrane, anti-EMA, and TTF, thyroid transcription factor. Thyroid transcription factor. You know what are the molecular genetics? I have already written over there. So this is basically adenocarcinoma. This is basically adenocarcinoma, the pattern of growth. They grow in acinar, papillary or tubule formation, and to sometimes bronchoalveolar growth pattern, which I am explaining. It happens predominantly in the location-wise peripheral portion of the lung. Women, and to a certain extent, not its association with smoking is less as compared to squamous and small cell carcinoma. It can be graded into well, moderate and poorly differentiated. You know what are the sites of metastasis, and these are the immunohistochemical aspects. Bronchoalveolar carcinoma is nothing but a special type of adenocarcinoma which grows in a lipidic pattern. It grows along the alveolar septal walls. It grows along the, this is adenocarcinoma. It grows along the alveolar septal wall. See, these are all the acinar and the papillary growth patterns of adenocarcinoma. They are very well tubule formation. This is not squamous cell carcinoma because they are tubule formation. And when you compare these pictures with this picture, see this and this are similar. The tumor cells grow along the alveolar septa. This has been called lipidic pattern. What is lipidic? It has been equated to butterflies. But what butterflies? Butterflies sitting on a fence. Butterflies sitting on a fence. So the tumor cells prefer to grow along the alveolar septa, which is called lipidic growth pattern. Butterfly sitting on a fence. That is the typical explanation. Butterfly sitting on a fence. So bronchoalveolar carcinomas, they can present as single or diffuse multiple nodules. And when they present as diffuse multiple nodules, surgical excision is quite difficult. That lipidic growth pattern which I have explained, and it can have mucinous and non-mucinous patterns. Mucinous and non-mucinous pattern. So this is basically the tumor mass. This is a papillary pattern of growth. This is the typical tubule formation or acini, and this is a bronchoalveolar pattern of growth where the tumor cells grow along the alveolar septa. These are all the cytological examinations. These are all the cytological examinations of sputum or bronchial lavage and all. So coming to the small neoplastic, small cell carcinoma, the small cell carcinoma are associated, with smoking, and it has the worst prognosis. It has the worst prognosis. Okay. Routes of spread, you know. I'll straight away go to the morphology. How do you make out non-small cell carcinoma? The small cell carcinoma. First, it's a nuclear size. They are small in size with very scanty cytoplasm. They are small in size with very scanty cytoplasm. And there is nuclear molding. The nuclear molding is very prominent, and the granular and the chromatin pattern is granular. It has been equated to salt and pepper pattern. Let's remember the names, salt and pepper pattern. So these cells are small in size, and because they are small in size, they have very scant amount of cytoplasm. There is prominent nuclear molding. And the chromatin pattern is equated to salt and pepper. It's granular in appearance. So that is called salt and pepper pattern of chromatin. Salt and pepper pattern. Cytoplasm is scanty with ill-defined borders. So these are the points you must remember. Again, if you see the small cell carcinoma, there is a small cell carcinoma. This is a central growth, and unlike squamous cell carcinoma, which is also centrally located, this is peribronchial growth pattern. Peribronchial, which is peribronchial means what? Endobronchial means it grows inside the bronchus. Excuse me. Peribronchial means it grows around the bronchus. And when it grows in size, ultimately it will cause, to some extent, luminal obstruction, the endobronchial obstruction, which will ultimately result in collapse of the lung. And this particular tumor is associated with what? This particular tumor is associated with paraneoplastic syndrome, which I have taken, and I am not explaining anything on paraneoplastic syndrome now, which is going to take up a long time. This is associated with small cell carcinoma. Which lung cancer is associated with paraneoplastic syndrome? Small cell carcinoma of the lung. Okay, these are all the paraneoplastic syndrome. Again, they have particular genetic changes, the particular genes, the oncogenes and tumor suppressor genes must be known to you, at least a few names, which is given here. And when we talk of immunohistochemistry, immunohistochemical markers, this is positive for what? This is positive for chromogranin, synaptophysin and LEU7, and the most important one is NAC, neuron specific enolase. NAC, the neuron specific enolase, LEU7, etc., etc. So synaptophysin, chromogranin, okay. So these are the markers which are positive, which is not, no cytokeratins, no EMA, no CEA. So this is the particular pattern of growth. Salt and pepper pattern. Okay. There are nuclear molding and all which I am being able to make out. But looking at the slide, you can make out. If you know how squamous cell carcinoma and adenocarcinoma looks like, you can easily differentiate it. You can easily differentiate squamous and adenocarcinoma from small cell carcinoma of the lung. Okay. Then comes large cell carcinoma. Large cell carcinoma, as the name suggests, it can have any kind of growth pattern. It can have any kind of growth pattern. This is basically undifferentiated. It's very difficult to make out what pattern it represents. So that is why we call it undifferentiated or large cell carcinoma. There is a strong association with cigarette smoking, which is highly aggressive, associated with early metastasis. Excuse me. Which is associated with early metastasis. Okay. So I'm not explaining much about large cell carcinoma. They won't ask you too much, but at least you should know the squamous cell carcinoma, the adenocarcinoma, the bronchoalveolar carcinoma and small cell carcinoma. These four must be known to you. So coming to the diagnostic modalities, they may ask you lab diagnosis. In lab diagnosis, only lab diagnosis they won't ask you. They will ask you how do you diagnose a case of lung cancer. Lab diagnosis has important role to play, but other than that also you have the chest x-rays where you can easily make out the lung cancer. The chest x-rays, then mediastinoscopy. Mediastinoscopy is for mediastinal involvement to check whether the lung has spread to the mediastinum or not. Then CT scan. CT scan enables the surgeon to know whether the tumor can be resectable or not. For example, in CT scan, if the size of the draining lymph node is more than 2 centimeter, that represents lymph nodal metastasis, lymph nodal involvement. Whereas a lymph node less than 2 centimeter in size, it's highly unlikely that a tumor has spread. Tumor has metastasized to the lymph node, tumor has spread to the lymph node. Okay, that is important. The 2 centimeters is arbitrary, that cutoff point, which enables the surgeon to identify in a CT scan whether there is spread of the tumor to the draining lymph nodes or not. So more than 2 centimeter represents, there's high possibility that the tumor has spread, whereas less than 2 centimeter, tumor probably has not involved the draining lymph nodes. Then comes MRI. MRI, you all know what is CT scan, what is MRI, at least you know the full form. So MRI represents what? MRI represents metastasis. It shows whether there has been metastasis of the bronchogenic carcinoma or not. Then comes PET, positron emission tomography. Positron emission tomography with FDG, fluorodeoxyglucose. So here this is the fluorodeoxyglucose is basically a dye which is injected, and the tumor cells avidly takes up the dye, which can be seen. So FDG, fluorodeoxyglucose, PET with FDG. In FDG is basically a dye which is injected and the tumor cells take it up avidly. Then finally comes biopsy. Okay. Oh, sorry. After that, there is fiber optic bronchoscopy, which is used to take biopsy. Then sputum examination, bronchoalveolar lavage. Finally, biopsy, which can be again bronchial, transbronchial, ultrasound or CT guided. See, we rarely get an entire specimen of lung. The lung cancers that we get, the biopsies that we get are small tissues based on which we have to diagnose. So ultimately, all these points must be in your mind, and you should be able to write. If you see what, if you mention all these points, you have earned yourself more than enough marks. Trust me. This is, I've taken it from Vinay Kamal. I'm telling you the book, and this is very beautifully represented over there. At least for your level, this is very important. Okay. And then the immunohistochemical markers and all those things have been mentioned. Finally, these are the serum tumor markers. These are all the serum tumor markers. Just study it. I'm not explaining now. But the point is, my last question is, how many of you would actually follow this? How many of you would actually follow this? Especially the medical students. We tell people not to smoke, but don't we smoke? As students also. Huh? So isn't it true? Is this not true? Kishan, is this not true? How many of you think this is correct? And how many of you think this is correct? Yes or no? And I know many of you do that. I did it. And many of you do that. And maybe I'll be typing all about lung cancer and take a break. That happens to everyone. So, no hiding it, but you should try to cut off as much as you can. That's all. Okay, so that finishes your bronchogenic carcinoma, and Thursday, madam will be taking on, I think, obstructive lung disease. That's what she will be taking. It should have been the other way around. Bronchogenic carcinoma, it should have ended with bronchogenic carcinoma, but madam had some work, so she had to leave. It was an emergency. So madam will be taking on Thursday on COPD. The most important from your point of view would be emphysema. Okay, so thank you.
আর কি আছে তাহলে? এরপরে তুমি যেটা বললে যে SGLT2 inhibitor, these are oral drug. And these are flozin group of drugs. Canaflozin, dapaflozin, these are flozin group of drugs. এইভাবে মনে রাখতে হবে। আর miscellaneous এর মধ্যে তুমি বলেছো dopamine agonist, that is the bromocriptine, it is not used, though because some clinical trials are being going on, and it has got various types of side effects, D2 agonist. That's why it is not used in other CNS diseases. And the third one is the most recent drug, that is the glitazar, seroglitazar. So these are all anti-diabetic drugs other than insulin. So how does it differ from oral agent? That means the drugs which can be given by oral route and which act by stimulation of insulin release, those are oral hypoglycemic agents. And you have to classify or change your classification like that. Okay. Okay.
Thank you, sir.
SGLT2 নোট ওতে এইমাত্র এখানে লেখাও আছে এখন দেখুন ইনসুলিন সেন্সিটাইজার থায়াজোলিডিন ডায়ন্স ট্রায়োগ্লিটাজন এছাড়াও যে রিসেন্ট ড্রাগ যেটা গ্লিটাজার দ্যাট ইজ ইউজড দ্যাট ক্যান রিডিউস ইনসুলিন রেজিস্ট্যান্স হ্যাঁ বলো তুমি আগে এটা বলবে কেন ঠিক আছে ইনসুলিন রেজিস্ট্যান্স কনসিকুয়েন্সেস অ্যান্ড ট্রিটমেন্ট অফ ইনসুলিন রেজিস্ট্যান্স It is very, very, very important. As a short note, it may come in theory.
Hello, myself Niladri Das, second year MBBS student. I am starting my topic, insulin resistant consequences and treatment. So first, little bit about insulin. Insulin, we know that it is secreted from the beta cell of pancreas, and it helps in to maintain the blood glucose level. Now it causes the glucose uptake to liver, muscle cells, and etc. Now when we see that certain amount of dosage of insulin after giving, the cell does not respond properly. So that become insulin resistant. So definition, the condition in which normal amount of insulin are inadequate to produce a normal insulin response from fat, muscle, and liver cells. This is the definition of insulin resistant. Now coming to the next slide. Now coming to the etiology and the causes of insulin resistance. First, there is genetic factor. The genetic factor will be in the next slide. Now coming to the medication. In the medication, you have steroid and glucosamine. And in some condition, you can see the insulin resistance like obesity, metabolic syndrome, pregnancy, and infection, severe illness, and stress, etc. Now, genetic etiologies of insulin resistance. We can see the children also in some certain autosomal recessive disease and like myotonic dystrophy, ataxia, telangiectasia, Alstom syndrome, polycystic ovarian syndrome, Werner syndrome, etc. Moving to the next slide. Now, when we do the global prevalence and case study, now we can see that an analysis from 2003 of the National Health and Nutrition Examination Survey data showed insulin resistance effect about 22% of the United States adults older than 20 years. A more recent analysis on Nutrition Examination Survey data from 2021 found that 40% of United States adults aged 18 to 44 are insulin resistant based on HOMA-IR measurement. So we can see that in the United States, more than 40% are insulin resistant in the ages of 18 to 44. This is we see in the global prevalence and case study when we do the community visit. Now coming to the next slide. So easily you can see when you feel tired and hungry, you go for eating food. Now food makes your insulin, but cell resist insulin occur due to those reasons, and this causes the sugar which stores as a fat. This is a small cycle we can see. Now this is the insulin resistance. Now we have to measure it. There are several processes how to measure it. First, there is hyperinsulinemic, euglycemic clamp, then insulin tolerance test, then minimal model test, homeostatic model, and then it is the quantitative insulin sensitivity check index. We are coming to this one by one. Next slide. In the next slide, you can see hyperinsulinemic euglycemic clamp, a measure of peripheral insulin sensitivity. High insulin infusion rate for 80 milli-international unit per meter square body surface area. Variable infusion rate of dextrose to keep blood glucose levels in the range of 90 to 100 milligram per day. A higher glucose infusion rate indicates better insulin sensitivity. So we can see that when there is glucose infusion rate, the more the glucose infusion rate, the more is the insulin sensitivity. This is one of the methods. Now coming to the next. Now this is the homeostatic model test. In the homeostatic model says we see that there is a fasting glucose level and there is a fasting insulin level. You know that fasting glucose, plasma glucose level 70 to 110 milligram per deciliter, and for the fasting plasma insulin level we know that it is 3 to 5 milli international unit per minute. So this is very helpful to estimate the plasma insulin level and used to access hepatic insulin sensitivity and lower score indicate better insulin sensitivity. Now next slide. This is the measurement of insulin resistance. So this is the method. This is the homeostatic measurement or assessment of insulin resistance. This is seen by fasting glucose, which is in millimole per liter, and to fasting insulin. So, and this y divided by 22.5. So the fasting insulin level will become more than 5, then it becomes to the proceed to the diabetes. Quantitative insulin sensitivity check index. This is also the measurement of insulin resistance, which is seen by 1 by log fasting insulin microunit per milliliter plus log fasting blood glucose level, which is in the milligram in day. So this is the method by which we can calculate the insulin resistance. Now next slide. So after all this, we can see who is the main risk for the insulin resistance. So we can see overweight patient with a BMI more than 25, and then we can see obese class 1 patient. Then a man with a waist more than 40 inches or a woman with a waist of more than 35 inches, and we can see in the 40 years, more than 40 years of age. Now in African, in American, in Native American or Asian American, and mainly we can see the family history with type 2 diabetes and hypertension or arteriosclerosis and have had gestational diabetes. We can see in the class of hypertension, blood glucose in the triglyceride level and low HDL. So in the obesity, we can see that 50 to 80% of the polycystic ovary syndrome are obese, and obesity-induced hyperinsulinemia contributes to obesity-specific insulin resistance. Insulin resistance of PCOS is a genetic and obesity ordinance. The next slide. So this is a graph. You can see the insulin resistance and obesity. So first we can see the insulin level in blood, and it is the time, and it is the insulin level. So in the night we can see this is in the obese person, people, and this is in the normal people. So in the obese people, you can see everything higher, and higher insulin levels are required to control blood glucose level in the insulin resistance and obese individual. And this is insulin level in blood. In the normal it is low, and in the case of obese people it is going higher spike, and blood insulin rises from basal level after its mean. And this is the glucose level in blood. We can compare both the two graphs. And in the case of glucose level, blood glucose is kept within the same narrow range throughout the day in both normal weight and obese individuals. So it is glucose level in blood. We can see that obese and normal both are in the equal range, but in the case of insulin level, it is the obese people have the higher. Coming to the next. So this is a graph, and this is the mainly graph which is insulin resistance solved with the type 2 diabetes parameter. When we can see this is the time and this is the levels of the insulin resistance. When insulin levels rises nearby one, and but the glucose level is equal at the x-axis. So insulin level rises, but glucose levels are still maintained in the insulin. But when in the case of going to type 2 diabetes, you can see that glucose level is increasing, but the insulin resistance is decreasing from it. So this is the main graph, and this is the graph between insulin resistance and type 2 diabetes. In the previous, we see that insulin resistance with the obesity graph. Now coming to this part, this you can see the interrelation between obesity, insulin resistance, and diabetes. So actually what happens that when is the environmental factors which causes obesity, and obesity releases TNF-1 necrosis factor alpha resistance and leptin and also free fatty acid which causes insulin resistance, and insulin resistance which become in the liver and muscles which causes the insulin tolerance and which causes the diabetes mellitus. If there is defect in the insulin secretion, this insulin secretion also causes the diabetes mellitus. Then there is a genetic predisposition which causes it, and glucose and lipotrophinia, etc. They are causes to diabetes mellitus. So this is the mainly interrelation between the obesity, insulin resistance, and diabetes mellitus. Insulin resistance is mainly related to these two topics with obesity and diabetes mellitus. Now back to the previous slide. Now coming to the clinical features, we can after all we can see that medical condition associated with insulin resistance. But we can see mainly to you see the type 2 diabetes mellitus, fatty liver, and then arteriosclerosis. So what is the metabolic syndrome? We can see the skin rashes in the body which is called acanthosis nigricans. Also in polycystic ovarian syndrome which is the 50 to 80% in the woman. Now as you can see the growth abnormalities. Coming to the next, this is the insulin resistance syndrome. In the clinical manifestation, we can see central obesity, acanthosis nigricans, and type 2 diabetes mellitus, and also fatty liver, etc. And when we come to the biological abnormalities, when we do the test of biochemical test, you can see the glucose tolerance. This is insulin resistance, also hyperinsulinemia, and in the case of dyslipidemia, we can see the liver lipid-related all the disorders like high triglyceride and HDL good cholesterol level is also decreased, and then LDL also increased. And we also see the vascular abnormalities like abnormal thrombolysis, endothelial and smooth muscle cell dysfunction. Also in the level, in the increase in the level of uric acid. So already we seen this. Now all this insulin resistance and consequences over. Now coming to the main part, which is the treatment, which is very important. Now how the obese person can equal to insulin resistance? We have to do weight loss. So weight loss causes reduced insulin levels, which can improve the status of clinical, which is called metabolic and endocrinal, and androgen levels fall by 44%. So first is the weight loss is the first line of therapeutic. So we can cause the weight loss. Now we come into the dietary components which may affect the insulin resistance. So what is the which causes the decrease in insulin resistance and which causes the insulin resistance? We have to eat the whole grains, fruits and vegetables, etc. and low fat dairy products, magnesium, calcium, dietary fibers, omega-3 fatty acid like linoleic acid, low GIT foods, magnesium, calcium, etc. We can do with this. So mainly we have to decrease the foods like cholesterol level. This type of food we have to decrease. So we have to avoid what type of food? We have to avoid saturated food. We have to avoid alcohol. We have to avoid salt. So if we maintain these dietary components, which may affect, that can lead to a better insulin resistance way, and this all will help us to overcome the insulin resistance. So this is the final, and we have to do what we have to do for insulin resistance. We have to do diet, we have to eat fruits and nutrition, weight, do exercise, food. Overall, you have to make a balance on the dietary components so that we can avoid the treatment and avoid from the insulin resistance and insulin resistant syndromes, etc. So this is over. Thank you.
When you will be asked about insulin resistance, write as a short note. Write as a short note. What will you write? First of all, definition of insulin resistance, what he said, that is the inability of the body to reduce the blood glucose level after a particular defined dose of insulin. Defined dose of insulin. So that is a state of insulin resistance. কখন বলবো? When the patient insulin requirement is more than 200 unit per day. More than 200 unit per day. The definition গেল। তাহলে who are
এতে
susceptible?
যাবে নীলাদ্রিতি বলে
Elderly person, number one, obese patient, and certain endocrine disorder or disease. And in addition, certain drugs can cause itself insulin resistance. হয়ে গেল susceptible individual। আর কারা যারা আছে sedentary worker, যারা সবসময় ল্যাপটপ নিয়ে বাড়িতে বসে কাজ করে, বাইরে no physical activity, they are prone to develop insulin resistance if they are diabetic. এটা গেল। এবার হচ্ছে যে which organs are mainly the sites where there is development of insulin resistance? কোনটা যদি আমি অ্যাকশন বলি তাহলে কোনটা হবে? মাসল অ্যান্ড অ্যাডিপোজ টিস্যু, মাসল অ্যান্ড অ্যাডিপোজ টিস্যু। আর কোথায় হবে যদি আমার ডিফেক্টিভ ইনসুলিন তাহলে কি হয়? সাইট অফ দ্যাট ইজ দ্য প্যানক্রিয়াস। আর নেক্সট ইজ দ্য লিভার। এই সাইট গেল। এবারে যে আর একটা হচ্ছে সেলুলার লেভেলে কী হতে পারে? একটা হচ্ছে প্রি রিসেপ্টার, পোস্ট রিসেপ্টার। প্রি রিসেপ্টার কখন? যখন অ্যাবনর্মাল ইনসুলিন থাকবে অথবা ইনসুলিন অ্যান্টিবডি থাকবে, কাজ করতে দেবে না। রিসেপ্টার হচ্ছে নাম্বার অফ রিসেপ্টার কম আছে, মিউটেশন অফ রিসেপ্টার হচ্ছে। তাহলে রিসেপ্টার abnormality in the beta cell function, that is the beta cell itself is defective. আর থার্ড কি? পোস্ট রিসেপ্টার। পোস্ট রিসেপ্টার কোনটা হবে বলো? পোস্ট রিসেপ্টার মানে অ্যাকশন হচ্ছে না, আমার ইনসুলিন আছে কিন্তু পেরিফেরিতে অ্যাকশন হচ্ছে না। কেন হবে না? মাসলে মানে গ্লুকোজ ট্রান্সলোকেশন, দ্যাট ইজ ডিফেক্টিভ ট্রান্সপোর্টার ব্লাড ফ্লো। ঠিক আছে, এই হয়ে গেল তোমার অ্যাডিকুয়েট ফিজিক্যাল অ্যাক্টিভিটি। আর কি হবে? যদি পেশেন্ট ইনসুলিন নেয়, যদি কনভেনশনাল ইনসুলিন নিয়ে থাকে তাহলে মোর পিউরিফাইড ইনসুলিন, হিউম্যান ইনসুলিন নিতে হবে। আর তাছাড়া আর কি হবে? আমরা কিছু ড্রাগ অ্যাড করতে পারি, যেমন থায়াজোলিন, পায়োভিটাজন লাইক, অথবা রিসেন্ট ড্রাগ বিটাজার, দ্যাট ক্যান বি ইউজড। আর হচ্ছে যদি কোনো মেডিকেশন হয় যেমন স্টেরয়েড, তাহলে আমাকে ওই স্টেরয়েড বন্ধ করে অন্য কোনো ড্রাগ দিতে হবে। আরও অনেক ড্রাগ আছে যেগুলো তোমার ইনসুলিনে কাজ করতে যায় না, ডায়োটিক, থায়াজাইড, ফুসেমাইড, এগুলো কাজ করতে যায় না, তাহলে আমাকে শিফট করতে হবে এরকম। আর যদি কোনো ডিজিজ থাকে যেমন, সেই ডিজিজের ট্রিটমেন্ট, অ্যাডিকুয়েট ট্রিটমেন্ট। তাই তোমাকে শর্ট নোট তো 3 নম্বরে থাকবে, তো তোমাকে কাটছাট করে এত কিছু তখন লেখা যাবে না। এটা হচ্ছে প্রেজেন্টেশন অফ ইনসুলিন রেজিস্ট্যান্স। এটা ঠিক আছে, তোমাকে লেখার সময় কিন্তু এইভাবে পয়েন্ট করে লিখতে হবে। ডু ইউ ফলো? ঠিক আছে।
It's on sulfonylurea group of drugs. So what are sulfonylurea group of drugs? They are actually insulin secretagogues. Now what is secretagogue? There are 2 types of secretagogues, that is sulfonylureas and meglitinides. So secretagogues are those substances which will increase the secretion of insulin hormone or any other kind of hormone like calcitonin, whatever. They will increase the secretion. These are known as secretagogues. Now let's go to the next slide. So yes, see, insulin secretagogues. These substances act by increasing insulin secretion. And how will they do that? They will inhibit the ATP sensitive potassium channels. Now on inhibiting the ATP sensitive potassium channels, what will happen? The potassium is not going out, so for that reason there will be depolarization, and for that reason the calcium will enter, which will result in the vesicles containing insulin to fuse with that of the cell membrane, and then the exocytosis of insulin will take place. So see, they are also known as oral hypoglycemic agents, OAJ, or we can also call them AAJ, that is anti-hyperglycemic agents. And for them to action, there should be at least 30% of beta cells that should be present. And side effect, we all know, hypoglycemia, because they are controlling the glucose levels. So if they decrease the glucose levels too much, then there will be hypoglycemia. So going to the next slide. Okay, so sulfonylureas, these groups of drugs were they actually were started from 1960s. Now at that time there were this first generation and second generation. Second generation came later. First generation is chlorpropamide and tolbutamide. And second generation is glipizide, gliclazide, glibenclamide, and finally the latest one is glimepiride. Now see, as I have told you, the mechanism of action of insulin secretagogues, okay, like sulfonylureas and meglitinides. I have already told you this oral hypoglycemic agents. Insulin secretagogues are also known as oral hypoglycemic agents, and they are sulfonylureas and meglitinides. Over here you can see this is the ATP sensitive potassium channel. Now over this ATP sensitive potassium channel there is a small portion SUR1. This is sulfonylurea receptor 1. Sulfonylurea receptor 1 is a portion, is a small part of this ATP sensitive potassium channel. Now when this SU or meglitinide both can act on it, so sulfonylureas when they are attaching on this SUR1 receptor, they will cause the inactivation of this ATP sensitive potassium channel, and what will happen, the intercellular potassium concentration will increase because the potassium is not able to go out because this is inactivated. And now what will happen, as the membrane is depolarized, so calcium will enter inside and will cause the insulin to go and fuse with this membrane of this beta cell, and the insulin will be secreted out. So this is the mechanism. And let's go to the next slide. Okay, so mechanism of action, sulfonylureas bind to a specific sulfonylurea receptor, that is SUR1, located on the pancreatic beta cell membrane, as I have already told you, and promote a brisk release of insulin. The mechanism of action is shown in the previous slide, as I have showed you, and the rate of insulin secretion at any glucose concentration is increased. That is, insulin released is provoked even at low glucose concentration. Even at low glucose concentration, if you give sulfonylureas, still there will be secretion of insulin, and there will be severe and uncontrolled hypoglycemia. So in type 2 diabetes mellitus, the kinetics is delayed. You know why? The answer is written over here. Because there is delayed and subdued because the transducer mechanism linking insulin receptors to the response is faulty rather than the receptor itself. Over here, as I have showed you, this receptor is not problematic. The transducer mechanism is problematic in case of type 2 diabetes mellitus. Okay. Now, going to the next slide, this is the extrapancreatic action, and this is very much important. You know why? Because see, after a few months, after we are administering this, after the administration of this sulfonylureas, the insulinemic action will decline. Okay, the insulinemic action will decline, and this is due to the probable reason is the downregulation of the SUR1 receptor on the beta cells, but improvement in glucose tolerance is maintained. Now pay very close attention to this. In this phase, they sensitize the target tissues, especially liver, to the action of insulin. Now there is a hypothesis that long-term improvement in carbohydrate tolerance lead to overall lowering of circulating insulin concentrations, which reverses the downregulation of insulin receptors. An apparent increase in their number occurs because see, as the downregulation of insulin receptors have occurred, so apparent increase in the number will occur, and a post-receptor action translation of receptor activation. So what is happening over here is that first there will be downregulation of SUR, but improvement in glucose tolerance is maintained. Next, the sensitization of the target tissues is there, and especially liver. Now there is, due to the improved glucose tolerance, there is lowering of circulating insulin concentration. As the circulating insulin concentration is lowered, for that reason, there will be increasing in the insulin receptors. See, reverses the down regulation of insulin receptors, which means there will be increase in the insulin receptors because the circulating level of insulin is reduced, and for that reason, this is the extrapancreatic action. Now, pharmacokinetics is that all sulfonylureas are well absorbed orally, and a 90%, up to 90 to 99% is well bound to the plasma glucose level, plasma proteins. And what will happen for that? volume of distribution will decrease because it is bound to plasma protein is not entering the tissue, so volume of distribution will decrease, and they are primarily metabolized, may produce active metabolites. Oh, okay, now there is one drug which I have already showed you before in the previous some slides before that. There is a drug named glimepiride. Glimepiride will be converted first to M1 metabolite, which is 1/3 active, and then it will be converted to M2 metabolite, which is inactive, and 65% will be excreted to feces and urine, and it is mainly metabolized by oxidative metabolism in the liver. So these active or inactive metabolites are excreted, as I have told you just now, that they are excreted in the urine or in the feces. 65% is like that is excreted. As a result, they should be cautiously used in patients with liver or kidney disease because it is metabolized in the liver and it is excreted in the urine. So it should be very much cautiously used in patients of liver and kidney disease. Next slide. Okay. So interactions. Drugs that enhance sulfonylureas may precipitate hypoglycemia. Enhance means they will enhance the action of this sulfonylurea group of drugs. So they will displace the protein binding. As I have told you, sulfonyl group of urea drugs are bound 90 to 99% to the proteins, and that's why they have very low volume of distribution. But over here, these drugs, the entire group of drugs, they will enhance the sulfonylurea. First of them is that they will displace the protein binding. That is phenylbutazone, sulfonamide, sulfenpyrazone, and salicylate. This will displace the protein binding, so will enhance the action. And then there is inhibit metabolism or excretion. That is cimetidine. Cimetidine is inhibitor, cytochrome inhibitor. So cimetidine, ketoconazole, these are all cytochrome inhibitors. Sulfonamide, warfarin, clonalphenicol, acute alcohol intake. So these will cause the inhibition of the metabolism of sulfonylurea. So the action will enhance. And lastly, last but not least, there is synergized with or prolonged pharmacodynamic action, which means these salicylates, propranolol, sympatholytic, antihypertensive, lithium, theophylline alcohol, they will inhibit gluconeogenesis. And they will prolong the pharmacodynamic action. And for that reason, there will be enhanced sulfonylurea group of action, And then the drugs that reduce the sulfonylurea action, that is, they will decrease the action of sulfonylurea. And how will they do that? They will induce the metabolism. See, phenylbutazone over here, that is displacing it from the protein binding. So it will enhance the action. But over here, phenobarbital, phenytoin, rifampicin, chronic alcoholism, these all will induce the metabolism. All these phenobarbital, phenytoin, these are metabolized by CYP2C9. So, and over here, opposite action, suppresses insulin release. Okay, this will suppress the insulin. Another mechanism is these drugs will suppress the insulin release, which means that they will not let the insulin to come out from the beta cells. That is corticosteroids, thiazides, this loop diuretics like furosemide, torsemide, oral contraceptives. These. Next slide. Okay. Now adverse effects. Okay. So I have almost come to the end of this topic. And these adverse effects of sulfonylureas. First of all, there is hypoglycemia. Hypoglycemia is the commonest problem, may occasionally be severe and rarely fatal. Hypoglycemia occurs, okay, but that might rarely be fatal. It is more common in elderly, liver and kidney disease patients and when potentiating drugs are added. Potentiating drugs, as I have already told you, the drugs which will remove them from the protein binding, or the drugs over here, you can see, drugs which will inhibit metabolism or the synergize with or prolong pharmacodynamic action. These drugs are the potentiating drugs. Okay. Okay, so these are potentiating drugs. When they are added, they will cause hypoglycemia. Tolbutamide, as I have already told you, first generation. Tolbutamide carries lowest risk due to its low potency and short duration of action. As the generation increases, the potency increases. So tolbutamide is low potency drug, and treatment of hypoglycemia episode is due to glucose, maybe for a few days, because hypoglycemia can occur. Now, as the hypoglycemia is occurring, we have to give glucose for this hypoglycemia. Okay. So non-specific side effects, majority of diabetes started on sulfonylureas tend to gain 1/3 kgs of weight. Now, people on sulfonylureas, they are gaining weight, and this may be the consequences of insulinemic action of sulfonylureas. This is the probable reason. And nausea, vomiting, flatulence, diarrhea, or constipation, headache, and paresthesis. Sorry, I'm extremely sorry. This is not paresthesis, this is paresthesis. Generally, these are the mild effects. And adverse effects, like one more adverse effects which I found is the hypersensitivity, like rashes, photosensitivity, purpura, transient leukopenia, and really granulocytosis. Flushing and disulfiram-like reactions after alcohol is reported to occur in some individuals. Disulfiram-like reactions, we all know what happens when we take disulfiram after alcohol. These kind of reactions might also take place if after alcohol and this drug is taken. So, people who are taking alcohol and sulfonylureas, these disulfiram-like reactions will occur. Tolbutamide reduces iodide uptake by thyroid, but hypothyroidism does not occur. See, this is very important that tolbutamide might reduce the iodide uptake, but hypothyroidism is not occurring. Although it is reducing iodide uptake, but hypothyroidism is not occurring. And safety of sulfonylureas during pregnancy is not established. Similarly for glimepiride also, as one of my topic was the present status of sulfonylureas. The present status is that the second generation is more used, and glimepiride, as that was also one of my topic, glimepiride, which is a sulfonylurea, that is also secreted through milk. So it is advised to the nursing mothers, the lactating mothers, that they should not be on sulfonylureas, that is glimepiride. And so for that reason, change over to insulin is advised. So this was all about my topic. So thank you for being a wonderful audience. You guys are truly awesome. Thank you.
What is the advantage? After this present status, অনেক সময় question আসে, what is the present status of sulfonylurea group of drugs, of glimepiride? Number one, strong insulin secretagogue, very potent. It can reduce the hemoglobin A1C level almost সবচেয়ে বেশি 2%. এটা গেল একটা। আর কি? এদের মধ্যে কতগুলো ড্রাগ আছে যেগুলো অ্যাডভান্টেজিয়াস, যেমন গ্লিমেপিরাইড, আর একটা হচ্ছে গ্লাইবেনক্লামাইড। এদের আদার দ্যান ইনসুলিন সিক্রেশন ছাড়াও অন্য এফেক্ট আছে, অন্য অ্যাকশন আছে। দ্যাট ইজ দ্য দে ক্যান এনহান্স দ্য অ্যাকশন অফ ইনসুলিন, দে ক্যান এনহান্স দ্য অ্যাকশন অফ ইনসুলিন। আর অন্যগুলো তারা আবার গ্লুকাগন সিক্রেশনটাকেও বন্ধ করে, যার জন্য হাইপোগ্লাইসেমিয়া অনেক বেশি হয়। হ্যাঁ, স্ট্যাটাস মানে হাইপোগ্লাইসেমিক এপিসোডটা যদি হয়, ফ্রিকুয়েন্টলি হয়, হলে পরে খুব সিভিয়ার হয় এই। আর থার্ড হচ্ছে যে ফার্স্ট জেনারেশন হচ্ছে plenty of side effects, very important, starting from hypersensory reaction, blood dyscrasia, jaundice, সব কিছু হয়, অ্যালকোহল ডাইসালফাইড লাইক রিয়াকশন সব কিছু হয়, কিন্তু গ্লিমেপিরাইডে কিন্তু বা সেকেন্ড জেনারেশনে এসব কোনো সাইড এফেক্ট নেই। তারপরে ইনসুলিন অ্যাকশনটাকে প্রিজার্ভ করে। আর একটা যেটা বললো সেকেন্ডারি ফেলিওর কেন হয়, তুমি একটা ডিজিজ হর্সকে যদি হুইপ করো, প্যানক্রিয়াস তো বিটা সেল তো নর্মাল হেলদি না, তো ডিজিজড, একটু হুইপ করলে তখন উঠে গেল, দৌড়লো 100 মিটার, তারপরে কী হবে, আস্তে আস্তে ঢুকতে থাকবে। কিন্তু যে নর্মাল যার যে ব্লাড যে মানে হেলদি যে হর্স, সে কিন্তু ওই একই স্পিডে দৌড়চ্ছে। তার মানে তার ইনসুলিনের যে রিজার্ভটা ছিল, পাওয়ারটা ছিল, কমে যাচ্ছে। এটা সেকেন্ডারি ফেলিওর এখানে বেশি হয়। আর হাইপোগ্লাইসেমিয়া কেন বেশি হয়, এরা হচ্ছে ইনসুলিন যে সিক্রেশনটা হয় দুটো ফেজে হয়। একটা যে ফার্স্ট ফেজ জাস্ট আফটার মিল, আর সেকেন্ড ফেজ হচ্ছে জাস্ট পোস্ট প্র্যান্ডিয়াল হাইপারগ্লাইসেমিয়া, আর একটা হচ্ছে সেকেন্ড ফেজ। যারা সেকেন্ড ফেজটাকে কাজ করে তারা হচ্ছে মোর হাইপোগ্লাইসেমিক। সালফোনিলিউরিয়া হচ্ছে সেকেন্ড ফেজ যে ইনসুলিন সিক্রেশন সেটাকে বাড়ায়, যার জন্য এরা হচ্ছে বেশি হাইপোগ্লাইসেমিক। আর গ্লিমেপিরাইড তো বললাম তোমাদের, এই হচ্ছে অ্যাডভান্টেজ। আর এগুলো মোডালেস, আর বেশি সময় নেই, আমি আর বলছি না। আর এর সঙ্গে পরেরটা ছিল পরের ম্যানেজমেন্টটা পোস্ট প্র্যান্ডিয়াল হাইপারগ্লাইসেমিয়া। পোস্ট প্র্যান্ডিয়াল hyperglycemia is a frequent complication or the scenario that you will be able to know when you will be in practice. That is the fasting blood. After treatment, the fasting blood sugar level is normal, coming down, but the postprandial blood sugar level is not coming down. That is, those group of patients are known as stamped as postprandial hyperglycemic patient. What are the drugs that can be given? তার মানে যে ড্রাগগুলো postprandial, very short rapid action, short duration action, মানে 1 ঘন্টার মধ্যে পিকে যাবে আর 1 ঘন্টার মধ্যে চলে যাবে। নাম বলো একটা। ইনসুলিন সিক্রেটাগগ নাম বলো। ইনসুলিন সিক্রেটাগগ যাদের খুব র্যাপিড অ্যাবজর্পশন অ্যান্ড meglitine, that is the meglitine, non-sulfonylurea group of insulin secretagogue, that is the repaglinide, nataglinide, এগুলো হচ্ছে ইমিডিয়েট, এরা হচ্ছে ফার্স্ট ফেজে কাজ করে, ফার্স্ট ফেজ অফ ইনসুলিন সিক্রেশনটাকে বাড়ায়, যার জন্য এবল টু ট্যাকল দ্য ইমিডিয়েট পোস্টপ্র্যান্ডিয়াল হাইপারগ্লাইসিমিয়া। আর শর্ট অ্যাক্টিং বলে এদের জাস্ট খাওয়ার আগে দিতে হয় আর 3টে মেজর মিলের সঙ্গে দিতে হয়, একা সাধারণত দেওয়া হয় না, অন্য ড্রাগের সঙ্গে দেওয়া হয়। এর হাইপোগ্লাইসিমিয়া এর হতে পারে লাইক দ্যাট, বাকি সবগুলোই হচ্ছে এই সালফোনিলিউরিয়ার মতো। একমাত্র ন্যাটেগ্লিনাইড বোধহয় তোমার রেনাল ডিজিজে দেওয়া যায়, বাকিগুলো দেওয়া যায় না। এই হচ্ছে তোমার আর কি দেওয়া যেতে পারে, প্রিপ্র্যান্ডিয়াল ইনসুলিন দিতে পারি আমরা, প্রিপ্র্যান্ডিয়াল ইনসুলিন শর্ট অ্যাক্টিং, দ্যাট ইজ আলট্রা শর্ট অ্যাক্টিং ইনসুলিন দিতে পারি, যাতে আমার ইমিডিয়েট পোস্টপ্র্যান্ডিয়াল হাইপারগ্লাইসিমিয়াটাকে কন্ট্রোল করা যায়। তো দিস টু ড্রাগস, এই দুটো ড্রাগই তোমাদের সাফিসিয়েন্ট জানলে পরে। তারপরে ছিল যে জাস্টিফিকেশন অফ ইউজ অফ মেটফর্মিন, এর কিন্তু মেকানিজম অ্যাকশন কিন্তু লাইক দ্যাট অফ sulfonylurea, but not binding with the, not through the binding of the sulfonylurea receptor, but they itself block the potassium channel. They itself block the potassium channel. That is the repaglinide, nataglinide, miglitol. Next হচ্ছে management of justification of use of metformin in type 2 diabetic mellitus as drug of first choice in reference to its mechanism of action. আর একটা জিনিস যেটা সালফোনিলিউরিয়া হচ্ছে ওয়েট গেইন হচ্ছে একটা ভেরি ইম্পর্টেন্ট সাইড এফেক্ট, 2 থেকে 3 কেজি ওজন বেড়ে যায়। তাহলে তার মানে কি, একটা ওবেস পেশেন্ট যদি আসে, হ্যাঁ, তাহলে ধরো 5 ফিট 6 ইঞ্চেস তার হাইট, তার দেখা গেল যে মোটামুটি 90 কেজি ওজন, তাকে তো দেবো না আমরা। এগুলো খেয়াল রাখতে হবে। metformin is a very good and important drug and very old drug, very old drug. 1970 the first groupটা আসে fenformin, but it was withdrawn due to development of fatal lactic acidosis. Metformin does not produce usually lactic acidosis by itself, but if you give metformin in susceptible individual like patient with very critical situation, hepatic disease, renal disorder, heart failure, সেখানে কিন্তু ল্যাকটিক অ্যাসিডোসিস হতে পারে। কেন ইট ইজ দ্য ড্রাগ অফ ফার্স্ট চয়েস? Why metformin is a drug of first choice? Number 1, সবসময় মনে রাখবে, it is not a hypoglycemic drug. It is a euglycemic drug, মানে ব্লাড গ্লুকোজ যদি নর্মাল থাকে, তাকে যদি তুমি মেটফরমিন দাও, তার ব্লাড গ্লুকোজ লেভেল আর নামবে না। তার কারণ কি? ইট ডাজ নট কজ ইনসুলিন সিক্রিশন, ইট ডাজ নট কজ ইনসুলিন সিক্রিশন। তাহলে কি করে কাজ করে? ইট ওয়ার্কস থ্রু AMPK, that is the adenosine cyclic AMP dependent protein kinase activation. অ্যাক্টিভেশন করলে কি হবে? নিওগ্লুকোজেনেসিস বন্ধ হবে, 3টে হয়, ফ্যাটি অ্যাসিড অক্সিডেশন বাড়বে, গ্লুকোজ আপটেক বাড়বে, নিওগ্লুকোজেনেসিস কমবে, লাইপোজেনেসিস কমবে, আর টু সাম এক্সটেন্ট তোমার লিভার আর ফ্ল্যাটের অ্যাকশনটা, ইনসুলিন অ্যাকশনটা বাড়বে। এটা মনে রাখতে হবে। নাম্বার 1, দে অ্যাক্ট বাই মেইনলি রিডিউসিং দ্য নিওগ্লুকোজেনেসিস। কি হয়? গ্লিসারল বা ল্যাকটেক থেকে গ্লুকোজ বেরোয়, ব্লক দিস এফেক্ট। তো নন অক্সিডেটিভ মেটাবলিজমটাকে স্টিমুলেট করে, ফ্যাটি অ্যাসিড অক্সিডেশনটাকে স্টিমুলেট করে লিভারে, আর হচ্ছে গ্লুকোজ আপটেক, এই আর হচ্ছে নিওগ্লুকোজেনেসিস, এগুলোকে প্রিভেন্ট করে। এগুলো ছাড়াও এদের লিপিড প্রোফাইলের উপর অ্যাকশন আছে, এই জন্যই হচ্ছে ফর দিস রিজন দে আর দ্য ড্রাগ অফ ফার্স্ট চয়েস আনলেস কন্ট্রাইন্ডিকেটেড। মানে ওবেস পেশেন্ট যদি হয়, তাকে আমরা মেটফরমিন দেবো, নর্মাল বডি ওয়েট যদি হয় মেটফরমিন দেবো, একটু যদি রোগা হয় তাকেও মেটফরমিন দেবো, সবাইকে মেটফরমিন দেবো, আনলেস ভেরি ফিউ কন্ট্রাইন্ডিকেশন। আর হচ্ছে ইট প্রিজার্ভ দ্য ইনসুলিন, দ্যাট ইজ বিটা সেল ফাংশন। তার কারণ কি? যেহেতু হুইপ করে না ইনসুলিন রিলিজের জন্য, যখনই তাহলে কি এটা রেস্ট পায়, রেস্ট হলে পরে ইনসুলিনের রিসেপ্টর ভালো কাজ করবে, ইমপ্রুভড অ্যাকশন হবে। এ হচ্ছে মেটফরমিন। এর সাইড এফেক্ট কি? অনলি যা জিআই সাইড এফেক্ট। আর একটা কি হচ্ছে, ভিটামিন B12 ডেফিসিয়েন্সি হয়, অ্যানিমিয়া হয় অনেক সময়। তো জানতে হবে, মেটফরমিন দিলাম, আমার ভিটামিন অ্যানিমিয়া হয়ে গেলে কি রে, সালফোলিন ইউরিয়াতে অ্যাগ্রানুলোসাইটোসিস, এটা কি অ্যাগ্রানুলোসাইটোসিস হলো না? তোমাকে জানতে হবে যে ভিটামিন B12, তুমি যদি অ্যাগ্রানুলোসাইটোসিস মনে করে যদি ব্লাড পিকচার পাঠাও, তোমার TCDC আসবে, ভিটামিন B12 আসবে না। কিন্তু তোমাকে জানতে হবে যে ভিটামিন B12 ডেফিসিয়েন্সি হতে পারে, তোমাকে ইউ হ্যাভ টু ডু ভিটামিন B12 এস্টিমেশন। এই আর মেটফরমিনে হচ্ছে 0.5 to 1 গ্রাম থেকে শুরু হয়, দিনে 2 বার দেয়, এক্সটেন্ডেড রিলিজ ফর্মুলেশন আছে, সেটা দিনে 1 বার দেয়। ম্যাক্সিমাম ডোজ হচ্ছে 2 গ্রাম, ম্যাক্সিমাম ডোজ হচ্ছে মেটফরমিনের 2 গ্রাম।
Coronary artery syndrome, and before initiating anything or telling anything about coronary arterial syndrome, you must have some idea about atherosclerosis. So today's topic of discussion is atherosclerosis. This is not a basically theory class, this is just a practical class, DOP session. But atherosclerosis as such is not included in any gross specimen or microscopic examination. Basically this is a theory class, but that has to be taken under the heading of DOP. So what do you mean by atherosclerosis? প্রত্যেকেই তোমরা শুনেছো এই টার্মটা। What do you mean by atherosclerosis? What do you mean by atherosclerosis? Anyone? বলো, জোরে বলো। Anyone? Stand up and tell loudly. Exactly. So this is basically a change, suggest the pathophysiology and the whole portion of the terminology atherosclerosis. Athero and sclerosis. Sclerosis means hardening, and athero means there is something related to atheroma formation, that is plaque formation. Hardening. Change of artery vessel which undergoes hardening or stiffening or loss of elasticity. Hardening means either this is stiffening, that is ভালো ভাষায় আমাদের প্যাথোলজিক্যাল টার্মে বলে লস অফ ইলাস্টিসিটি, CT. Okay, this is due to why? Plaque formation, where in intimal layer of arteries. So loss of elasticity of arteries due to plaque formation at the intimal layer of arteries is known as atherosclerosis. Simple. কি হচ্ছে? What are the main arteries involved in atherosclerosis? What are the main arteries? So what are the main arteries involved by the atherosclerosis? The most common artery is abdominal aorta, okay. Next, so তোমরা হিস্টোলজিতেই বা অ্যানাটমিতে পড়েছো, all the arteries are basically divided into 3 main types: major artery, medium size artery, and small vessel vasculature. So large vessel vasculature or large arteries are mainly, it involves the large size and medium size arteries. So what are the large size arteries? Abdominal aorta. Next coronary artery. Next, cerebral arteries. Next, renal arteries. Renal arteries means superior and inferior extremity arteries, and also they involve superior and inferior mesenteric arteries, superior mesenteric and inferior mesenteric arteries, and also the internal and external iliac arteries. Why I am telling all the different names of main arteries? Why? Because the pathophysiology, that is the consequence of atherosclerotic plaque formation involving different types of arteries are different. কি করে আসছে কেন why the different types of arteries are involved? That is the nature. It usually involve the কি বলেছিলাম large and medium size arteries, medium size vessels, not the veins but the arteries, and the consequence of atherosclerotic plaque formation is different according to the site of involvement. So what is the main consequence of atherosclerotic plaque formation? Is just narrowing of the artery. Narrowing of the lumen of vasculature is the main consequence of atherosclerotic plaque formation. So suppose this is the lumen of artery. Just outside the lumen, I mean it is lined by endothelial, single layer of endothelial cell. This is single layer of endothelial cell. Just beneath the endothelial cell there is a substance material or subendothelial structures limited by and layer. So suppose this layer of endothelium with the endothelium there is some endothelial structure. Just beneath the subendothelial structure there will be intimal layer of artery. Below the intimal layer artery, this layer consists of smooth muscle. This layer consisting of smooth muscle. This smooth muscle layer is known as tunica media. And outside the tunica media there will be some serosal lining, adventitia, tunica adventitia. This atherosclerotic plaque formation occurring this portion at that portion. It involves the endothelium, subendothelial structure, intimal layer, and to some extent the tunica media. So basically, this area will ultimately convert it into a plaque. This area will convert it into a plaque. This plaque basically having a lipid content. Outside the lipid content, there will be so many inflammatory infiltrate, so many extracellular matrix protein, some fibrous tissue, I mean some elastic tissue, and it is covered by this yellow portion, it is covered by a cap known as fibrous cap, and below this fibrous cap there will be proliferation of smooth muscle, which is known as medial smooth muscle, tunica medial smooth muscle proliferation. So basically this plaque is causing nothing but narrowing of a particular affected blood vessel. So suppose this blood vessel is affected, so it gets down. It gets narrowed down. The amount of the blood flow through that particular blood vessel will be decreased, diminished. So ultimately that will cause decrease amount of blood flow through that particular channel or the particular organ which is supplied by that artery. So suppose why I am elaborating all these things, suppose abdominal aorta is affected. So what are the structures supplied by abdominal aorta? Almost everything. So initially this is the most common artery involved. So initially what are the main branches of abdominal aorta? Celiac trunk, superior mesenteric, inferior mesenteric. It usually involves the superior and inferior mesenteric vessel, artery. So if the superior and inferior mesenteric artery is involved, then that will hamper the blood flow of total gut. So it will cause chronic ischemia, chronic intestinal ischemia. In chronic, these are chronic form. Initially that will chronic form. So it will involve the superior inferior mesenteric artery is involved. Then initially that will cause the chronic enteric or intestinal ischemia. If the celiac artery is involved, then it will cause stomach gastropathy known as GAVE, gastrointestinal GAVE, vascular enteropathy. The underlying cause will be atherosclerosis. If the splenic artery is involved, splenic infarct formation. Okay. Suppose coronary artery is involved. It will ultimately cause stable or unstable angina, and in acute case, acute coronary syndrome. These three terminology are in toto known as ischemic heart disease because the underlying cause is ischemia. Suppose the cerebral artery is involved, that will cause, bolo, initially yes, syncope, but the major pathology either transient ischemic attack, TIA, or cerebrovascular accident known as stroke, TIA or CVM. ওকে, আপার মোটর নিউরন পলসি সমস্ত জানো এগুলো, মেডিসিনে পড়েছো তো। ইফ রেনাল আর্টারি ইজ ইনভলভড, সাপোজ দ্য রেনাল আর্টারি ইজ ইনভলভড, কি অ্যাকিউট, বলো অ্যাকিউট renovascular hypertension, chronic case renovascular hypertension, and if in case acute renal infraction, acute renal infraction, and in chronic case renovascular hypertension. Okay, and also if the hepatic artery is involved, usually in pregnancy state, it causes a umbrella syndrome known as HELP syndrome. HELP syndrome. Suppose peripheral arteries, superior and inferior extremities arteries are involved, intermittent claudication, Raynaud's disease and intermittent claudication. Okay, intermittent claudication and Raynaud's disease. If internal and external iliac artery involved, external and internal iliac artery involved, কাকে সাপ্লাই করে? So these are mainly the all type of infractive cases, infraction or ischemic cases of all different organs are involved, and the major underlying cause is atherosclerosis. So most importantly, acute coronary syndrome, small bowel ischemia or bowel ischemia, transient ischemic attack, stroke, peripheral vascular disease, intermittent claudication, renovascular hypertension, and acute renal ischemia. These are major symptoms, major consequence of atherosclerotic plaque formation. ঠিক আছে? So next portion is what are the factors involved in atherosclerosis? Renovascular hypertension and acute renal ischemia. এগুলো প্রত্যেকটা পোরশন আলাদা আলাদা করে আলাদা আলাদা সিস্টেমে তোমরা পড়বে। সিভিএস এর মধ্যে কোরোনারি ইসচেমিক হার্ট ডিজিজ, স্টেবল আনস্টেবল অ্যাঞ্জাইনা, and acute coronary syndrome or infraction. Acute myocardial infarction is the most important thing. So what are the factors involved in atherosclerosis? What are the main factors involved in atherosclerosis? The factors can be divided into two portions. That could be modifiable, that could be non-modifiable. এই পোর্শনটা ক্লিয়ার হয়েছে? আমি আরো প্যাথোফিজিওলজি যখন দেখাবো তখন আমি আরো ক্লিয়ারলি বলবো। Modifiable receptor and modifiable receptor. non-modifiable. What are the modifiable risk factors? Means if we do some exercise or we have take some we used to have take some pharmacological agent or do some physical activity, these risk factors can be stopped and the further pathogenesis of atherosclerosis can be halted. But non-modifiable risk factors are mainly genetic factors and some racial factors and other factors with which we cannot deal anything. We cannot modify the normal pathogenesis of atherosclerosis formation. So, what are the modifiable risk factors? Bolo? Most importantly, dyslipidemia. What do you mean by dyslipidemia? তোমাদের ফার্মা ক্লাস হয়ে গিয়েছে, বলো। LDL level high, high more than what? More than what level? Of course তোমাদের এইগুলোই জানতে চাইবে। Normal level of LDL, বলো বলো হচ্ছে বলো। Exactly. Normal level কি? Normal level কি? 60 to 80. More than 100 means LDL. Triglyceride কি কোনটা dyslipidemia? Hypertriglyceridemia. Is it associated directly with atherosclerosis? Directly atherosclerosis? Is it directly atherosclerosis? No, triglyceride is not directly associated with atherosclerosis, but the hypercholesterol level is directly associated with atherosclerosis. So, I am not putting this under the dyslipidemia. Of course, this is a dyslipidemia, but this is not a direct risk factor of atherosclerosis. So, increase cholesterol level, normal level, cholesterol normal level 80 to 140, more than 80 to 200, more than 260 is very bad thing. 260. Next, HDL level decrease of up to what content? Less than 50. These three things: increase HDL level, increase total cholesterol level, and decrease in HDL level. These three parameters have a direct effect on atherosclerotic plaque formation. Direct effect. Dyslipidemia, first one. Second, follow. Type. Which type? Diabetic mellitus. Which type? Which type of diabetes mellitus? 2. Type 2 diabetes mellitus associated with atherosclerotic plaque formation. Third, smoking. Smoking is injurious to health more than alcohol consumption. But more than smoking, কি জানো? Obesity. More than smoking. Especially which kind of obesity? Obesity পড়েছো? পড়া হয়েছে? Centripetal, centrifugal, এইসব obesity পড়েছো? আচ্ছা, ওটা যখন পড়োইনি জানবে অ্যাবডোমিনাল ওবেসিটি, ভুঁড়ি হয়ে যাওয়া, অ্যাবডোমিনাল ওবেসিটি। ওকে, নেক্সট, other than this, sedentary life. sedentary life. And one of the most important thing is hypertension. Hypertension, type 2 diabetes mellitus, obesity, smoking, alcohol consumption, sedentary life. These are all modifiable risk factors for the atherosclerosis plaque formation, atherosclerotic plaque formation. And under the non-modifiable factors, যেগুলো তোমরা চাইলেও চেঞ্জ করতে পারবে না, সেটা হচ্ছে সেক্স, অবশ্য চেঞ্জ করা যায় এখন, and male sex. Why? Because female up to menopause are protective from atherosclerotic plaque formation due to the effect of estrogen. Okay, up to menopause they are protective from atherosclerotic plaque formation usually due to the effect of estrogen, but the risk factor for atherosclerosis plaque formation is same in postmenopausal women and men are same. Okay, next, type A personality. টাইপ এ পার্সোনালিটি যারা সবসময় রেগে থাকে, যারা সবসময় কম কোনো একটা মানে কোনো অকারণেই আর কি উত্তেজিত হয়ে থাকে, যারা কোনো কাজে খুব সিরিয়াস থাকে, যারা ফাইট অ্যান্ড ফ্লাইটে বিশ্বাস করে, হ্যাঁ, যারা সবসময় একটা ছোট জিনিসেও মানে একটু বেশি রিয়াক্ট করে, দিজ আর অল টাইপ এ পার্সোনালিটি। ওকে, next, race, Asian, Hispanic and Caucasian. These three races are highly prone to develop atherosclerosis. Asian, Hispanic and Caucasian, and some genetic factor like familial, hypercholesterolemia, and one of the most important, metabolic X syndrome, familial hypercholesterolemia. These two are highly associated with the atherosclerotic plaque formation. ঠিক আছে? So these are the risk factors for atherosclerotic plaque formation. Now তোমাদের যেটা কোয়েশ্চেন আসবে সেটা হচ্ছে মেটাবলিক এক্স সিনড্রোম, তোমরা মেটাবলিক এক্স সিনড্রোম এটা তোমরা পড়বে, মানে আর কিছুদিন পরে তোমরা ওবেসিটি যখন পড়াবো তখন এটা আমি ওবেসিটি যখন পড়াবো তোমাদের মেটাবলিক এক্স সিনড্রোম আরো ডিটেইলসে পড়াবো। So what are the pathogenesis of atherosclerosis? Very important. One is diabetes. Okay. One is hypertension. One is smoking. And another is কি বলেছিলাম, the most important হচ্ছে dyslipidemia, তাই তো? ডায়াবেটিস কি করে? নরমাল মেটাবলিজম, insulin resistance that causes alteration of normal metabolism, especially alteration of fat metabolism, these are associated with high LDL level, true or false, high LDL level, and of course high cholesterol level. And hypertension is causing what? Injury to endothelium. Okay. Dyslipidemia is also associated with same high LDL and cholesterol level. And smoking causing this has an added effect. Added effect means this smoking causing oxidization of LDL. চারটে জিনিস বললাম। Diabetes causing alteration of fat metabolism, which ultimately leads to high LDL level and decreased HDL level. That is nothing but the same effect of dyslipidemia. Hypertension causing damage to the blood vessel. If it is a benign hypertension, then the change of the blood vessel is known as hyaline atherosclerosis. But if it is a malignant hypertension, if the malignant means if it is 160/100, then it will cause some hyperplastic atherosclerosis, arteriosclerosis. Atherosclerosis ক্লাসটা হয়ে যাক, আমি arteriosclerosis কি সেটা বলবো, hyperplastic atherosclerosis. So in both situation there will be ultimately causing the damage of endothelium layer, that is the immediate layer which is adjacent to the main channel of blood is damaged. True. And the effect of smoking is oxidation of LDL. It causing the oxidation of LDL, accelerated oxidation of LDL. এই চারটে পয়েন্ট মনে থাকবে। নাও ভালো করে বোঝো, কনসেপ্টটা ভালো করে সারা জীবন এই কনসেপ্টটা মনে রাখতে হবে। So ultimately injury to endothelium, that will cause endothelium injury. আচ্ছা, ইনফ্লামেশনের ইনিশিয়াল স্টেজে কি হয়? হ্যাঁ হলো, তারপর সিলেকটিন আর ভিক্যামের কি হয়? সিলেকটিন কি হয়? সিলেকটিন কোথায় থাকে? ই সিলেকটিন, পি সিলেকটিন, এল সিলেকটিন কোথায় থাকে? মেইনলি এন্ডোথেলিয়ামে থাকে, অথবা প্লেটলেটে থাকে, অথবা লিম্ফোসাইটে থাকে। ঠিক আছে, দে উইল বাইন্ড উইথ ভিক্যাম অর আইক্যাম। সেগুলো কোথায় থাকে? এক্সট্রাসেলুলার ম্যাট্রিক্সের মধ্যে থাকে। কি বলেছিলাম, একটা সাব এন্ডোথেলিয়াল স্পেস ছিল। এক্সট্রাসেলুলার ম্যাট্রিক্স কোথায় থাকবে? সাব এন্ডোথেলিয়াল স্পেসে। সো injury to endothelium will ultimately cause recruitment of inflammatory cell. Of course there will be recruitment of inflammatory cell due to VCAM or ICAM expression. So this ultimately causing recruitment of inflammatory cell. Monocyte is one of the inflammatory cell. True or false? Monocyte is one of the inflammatory cell. So আমি বলে নিতে পারি recruitment of monocyte. আমাদের কি হয়েছিল? এর মধ্যে আছে। And due to the high amount of neutrophil and different inflammatory cell, that will cause ultimately an inflammation, local inflammation, and as a part of local inflammation there will be an oxidative burst. There will be an oxidative burst. This oxidative burst are causing the oxidation of LDL. So as a part of recruitment of inflammatory cell and local inflammation, that is causing the initiation of oxidation procedure, and that oxidation of LDL is occurring by the site of at the same time of recruitment of monocyte, the LDL oxidation is occurring. This recruitment usually caused by the MCP1 monocyte chemoattractant protein 1, and when the monocyte usually accumulates within the subendothelial cell, there will be some normal histopathological changes of normal monocytes. They will produce some monocytic attracted proteins, cytokines, etc., and they will ultimately modified. No, they ultimately modified in subendothelial cell, which ultimately engulf this oxidized LDL. So this modified monocyte engulf oxidized LDL, and it ultimately converted into foam cell. বোঝা গেল? foam cell. So গোটা গল্পটা শুরু হয়েছিল একটা এন্ডোথেলিয়ামের ইনজুরি থেকে। That endothelium injury causing ultimately initiation of inflammation. This inflammation ultimately causing what? Monocyte accumulation at a particular subendothelial space, and by the site of monocyte accumulation there will be oxidative burst and ultimately causing the oxidation of LDL. Oxidized LDL are engulfed by modified monocyte. Modified monocyte has a peculiar histological changes. কি করে? তাদের মধ্যে modified monocyte এর মধ্যে রিসেপ্টরের মধ্যে LDL রিসেপ্টর গুলো সেলের বাইরে অ্যাকুমুলেট করে। So they easily can engulf the oxidized LDL, and this oxidized LDL, when they engulf, they produce some foam cell. So this is the first step. So আমরা foam cell foam cell examination that will known as fat streak. So foam cells when accumulate at the internal layer, that is tunica intima. কোথায় বলেছিলাম? সাবএন্ডোথেলিয়াল স্পেসে টিউনিকা ইন্টিমাতে যখন ফোম সেলগুলো অ্যাকুমুলেট করে, দ্যাট উইল অ্যাট গ্রস will look like a yellowish dots known as fatty streak. Okay, so in the next step কি হবে? This will accumulate, they will produce some matrix metalloproteinases, MMP, matrix metalloproteinases, which ultimately causes increased fibrogenesis by growth factor, beta, etc., different types of cytokines accumulation. As an effect of increased matrix metalloproteinases formation and different types of inflammatory cell infiltration at a local site, different types of cytokines can be released, and one of the most important cytokines in a chronic inflammations are transforming growth factor beta, platelet derived growth factor beta, which ultimately causing the fibrogenesis. So, surrounding this foamy cell, some elastin fibers are accumulated, and that will cause a cap formation. This is known as fibrous cap. So, surrounding the foamy cell, there will be fibrogenesis and fibrous cap will be formed. So, this fibrous cap plus collection of foamy cell altogether known as atheroma. This is the second stage. So, initially there will be fibrous streak, second there will be fibrous, there will be atheroma formation, and lastly this is basically a chronic inflammation. So, ultimately granulation tissue will be ultimately formed. In a process of chronic inflammation, there might be a consequence of dystrophic calcification also. So within the foamy histiocytes, these are histiocytes basically, within the foamy histiocytes, dystrophic calcification occurring, and when this atheroma plaque are calcified, they will produce hard calcified atherosclerotic plaque. Hard calcified atherosclerotic plaque. So, initially that was a very soft, karon at the core of the foamy, fatty streaks, there will be presence of just a cheesy lipid laden material. Surrounding in a gradual process, surrounding that lipid laden material, there will be fibrous cap formation, and the fibrous streak is converted into atheroma. So, fibrous streak is converted into atheroma, and within the atheroma, if there is dystrophic calcification in a process, that will change into a very hard calcified atherosclerotic plaque. So, a normal blood vessel which is initially was so elastic, ultimately go into a stage of very hard type of lead pipe type of blood vessel, hard lead pipe type of blood vessel. And if this blood vessel causing the narrowing of lumen up to 70%, there will be no change. But if there is more than 70% of narrowing, that will cause the critical ischemia, critical narrowing. Only symptoms appears when there will be involvement of more than 70% narrowing a particular blood vessel. এই জন্য এই যে ক্যালসিফাই, এখানে একটা ভালো ফান্ডা হচ্ছে, এই যে ক্যালসিফাইড হার্ড অ্যাথেরোস্ক্লেরোসিস আছে, একটা স্কোর করা হয়, সেটাকে বলা হয় ক্যালসিফিকেশন স্কোর ইন দ্য সিটি স্ক্যান। কার্ডিয়াক সিটিতে একটা ক্যালসিফিকেশন স্কোর করা হয়, ফ্রম দ্যাট ক্যালসিফিকেশন স্কোর উই ক্যান প্রেডিক্ট the prognosis of atherosclerosis in cases of ischemic heart disease. So, what are the consequences of that hard calcified atherosclerotic plaque? It's a very hard plaque. So, there will be a damage to the adventitial layer. So, it will ultimately cause the aneurysm formation. One, that will cause the aneurysm formation. Second, this atherosclerotic plaque is damaged. They get detached. Even this fatty streak or atheroma also get detached from a primary site, and they will go through the blood to a distant site and causing embolism, atheroembolism. This atheroembolism causing a particular if that atheroembolism causing narrowing of a particular end artery, that will cause a severe ischemia. Transient ischemic attack is one of the important consequences of that atheroembolism or CVA or that is the stroke. These are all consequences of atheroembolism. And third, there will be critical narrowing and complete occlusion of blood vessel. জানবে atherosclerosis আর একটাই পোরশন আছে মানে atherosclerosis, these are change of main blood vessel, but other than atherosclerosis there might be some other changes of blood vessel. They are known as arteriosclerosis. Arteriosclerosis. So what are the types of arteriosclerosis? What are the types of arteriosclerosis? These are the change of artery. That could be medium size, that could be large size, that also could be small size. But in medium and large size, the arterial changes are mainly pronounced. ভালোভাবে দেখা যায়. Okay. So what are the types of arteriosclerosis? Hyaline, hyperplastic, and necrotic. Hyaline means initially there will be, it usually seen in two conditions. One is senile. Oh, next another Monckeberg medial sclerosis. Medial sclerosis. কি হয়? Hyaline, one হচ্ছে senile change and another is benign hypertension. কি হয়? Initially there will be damage of endothelial cell and just damage of endothelial cell causing accumulation of some fibrinous proteinaceous material, fibrinoid মানে fibrin like. These are only protein which accumulate within the intimal layer, within the tunica intima. This is known as hyaline arteriosclerosis, usually seen in the senile condition and benign hypertension. But if the level of blood pressure is too much high, that is usually if it is more than 160 by 100, that is in case of malignant hypertension, that proteinaceous material, not only there will be accumulation of proteinaceous material, there will be reactive change of medial smooth muscle. That medial smooth muscle undergo proliferation, and this proliferative change of tunica media impart that condition known as hyperplastic atherosclerosis. Usually it is seen in case of malignant hypertension. And proliferation of tunica media histologically looks like onion skin appearance. Appearance in histopathological examination. Okay. Onion skin appearance of histopathological examination. It is seen in the hyperplastic atherosclerosis in cases usually as a consequence of malignant hypertension. Necrotic atherosclerosis, if there is a particular gangrenous change or there is a local inflammation which causing the accumulation of necrotic material within the tunica media, that is known as necrotic arteriosclerosis. It also seen in malignant hypertension. And Monkeberg medial sclerosis, it is nothing but deposition of dystrophic calcification within the tunica media, seen in case of senile condition. Next দিন আমি একটা করে জাস্ট একবার করে প্রত্যেকটারই ছবি দেখিয়ে দেব. These are the 4 changes of arteries, and the last, of course the last but not the least change is atherosclerosis.